Hi, good afternoon, everyone. Welcome again to our weekly research conference here at the University of Ottawa Heart Institute and also in the Ottawa region. And welcome back from our summer break. And I hope everyone did actually have a restful and enjoyable summer. And we are absolutely delighted to have Professor Le May today to give us a very exciting presentation. But before we start, I'd like to just give a few logistic reminders. So make sure that you can post your questions during the presentation using the Q&A feature on the bottom of your screen. And these will be answered in turn at the end of the lecture during the Q&A period. And if you would like to post the questions directly, we will be able to do that as well for you to pose a live question. And so you can use the hand up feature at the end of the presentation, and we will connect you and unmute you so that you can actually directly ask the question. So please feel free to use any of these modalities. If you do have technical issues, please use the chat function. And then Kelsey or Allison will connect with you to make sure that we can resolve any of these technical issues. So it's really a pleasure today to have Professor Le May with us to give us an update on some exciting concepts that he really actually has promoted. And the folks know that Dr. Le May is the director of the University of Ottawa Heart Institute Regional STEMI program. And he's also an interventional cardiologist who look after our patients wonderfully at the Institute. He's also a professor of medicine at University of Ottawa. He received a medical degree from University of Ottawa originally, then completed his training in internal medicine at University of Southern California, and then followed by fellowship at Emory University. And Dr. Le May has been absolutely passionate in terms of research in STEMI, that's acute myocardial infarction, and has published extensively on the subject. He pioneered the concept of the dedicated STEMI treatment suite, which has enabled paramedics to triage STEMI patients directly to the Heart Institute for primary PCI, resulting in 50% reduction in mortality for patients in the Ottawa region. And that's a huge impact. And as a recognized, accomplished clinical researcher, Dr. Le May has over 100 peer-reviewed publications and also presentations at important international venue. And he has received multiple awards, both in Canada and internationally. And I think some of the most important moments that we remember are his regular invitation for presentation of his latest research at the late-breaking trial sessions of major international meetings such as the ACC or AHA. And these are generally attended by thousands of attendees, whether directly or online. And Dr. Le May's work has always received accolades from some of the best experts in the field. Throughout his career, Dr. Le May successfully linked his research passion to his clinical care interests. His pragmatic approach to research resulted in immediate and meaningful impact on patient care. His research practical addresses important relevant questions and produces results that one can use readily for our patients, both here in Ottawa and the world over. And we're absolutely delighted today that Dr. Le May will be able to actually give us the story. That's the full story of the STEMI program and once upon a time. Michel, take it away.
Thank you very much for such a gracious introduction, Peter. So the objectives today is really to describe the evolution of care for STEMI patient. And I'm going to try to do this a bit as a story so that you understand where it's come from. We want to recognize the importance of time to reperfusion as a key determinant of prognosis, and recognize also the impact of research on the care of our patients. This slide illustrates a patient with a ruptured plaque in a coronary artery at a location where there's an atheroma, and it leads to platelet aggregation and a thrombus formation that occludes the artery. And when this happens, this is a catastrophic accident that leads to myocardial infarction and possibly death. We recognize here a patient with a STEMI with a large anterior wall, ST elevation myocardial infarction. And when we take this patient to the cath lab, what we note is an occluded proximal LAD. You can see at the top of the screen there, there's a vessel that's missing. And I think when we see this, we're always a little bit more anxious to get that artery open, because we know that this is associated with a large amount of myocardium that is being damaged. And that time is really critical for this patient. We've been doing this for some time now. We've been pulling clots out of the coronary arteries. The pathologists have been telling us that one of the problem has been clotting of the coronary arteries. And in the cath lab, we can aspirate thrombus out of the coronary arteries, and I'll tell you a little bit about that later on. So this slide illustrates, this is a slide from Gibson that illustrates the wave of myocardial necrosis that starts from the endocardium and moves towards the outside of the heart. And it doesn't take very much, and within 6 hours, there is damage that potentially is irreversible. So we have a limited amount of time to really get the coronary artery open. And that's why I think that this is why time is of such of essence. Now, back in the 60s, the CCUs were starting, and so were the Beatles. And on this album here called, this was a 45 RPM that was released. It had Revolution on one side, but on the other side, it had Hey Jude. But we thought that, you know, this was towards the end of the 60s, maybe perhaps that's where the STEMI revolution started, because the mortality for an anterior wall MI or a STEMI admitted to the unit at that time was extremely high, was above 20%. And there was a need to start doing something because there was no therapy available at the time. When you look back at how this all started, Dr. Keon, who was became a doctor of medicine from the University of Ottawa, then went to Harvard and came back to Ottawa in 1969, founded the University of Ottawa Heart Institute in 1976. Well, why do I bring up this slide? It's because at that time when he came back in his early career, he was recruiting patients with STEMIs and taking them to the OR and operating on them and saying, you need to reperfuse those vessels, and that's the only way to improve outcome. And so, you know, he was even taking patients with cardiogenic shock, and these patients were doing better. And it took almost 30 years later to show that actually reperfusion is the way to go in patients with cardiogenic shock. So Dr. Keon was well ahead of his time. In 1977, Andreas Grunzig in Zurich did the first angioplasty to open up an artery. And then that patient had serial follow-ups and his LAD remained patent. And here's a catheter that I had a chance to bring back from Emory University when I was in training, because Andreas Grunzig had moved to Atlanta, and I had an opportunity to scrub with him when I was a cardiology resident. And I took this catheter back, a very high profile, and also you see the guiding catheter there as well. But since then, angioplasty has just taken off, and we have better equipment in every way possible. The catheters have become smaller. The balloon catheters have become smaller. We have IVUS, we have OCT, we have stents, we have drug-eluting stents, we have the radial approach, we have atherectomy, protection device, aspiration devices. But going back now, in the 80s, they were busy trying to show that fibrolytic therapy was the way to go because it was be accessible to all population. And the ISIS-2 trial, just published in 1988, shortly after the GISSI trial, showed that even aspirin could reduce mortality by as much as 2.5%. And combining it with streptokinase, we were able to get a mortality reduction of 5.2%. And these were selected patients. There was a lot of exclusions before you got to these patients. So the placebo arm had a very high mortality, but you can imagine if I had used all patients, the mortality would have been even more excessive. So they decided to develop a grading system in order to determine how do you assess how well a lytic agent works. Because following streptokinase, there was a new agent called TPA, and TPA was supposed to be better in terms of opening arteries. So they developed a classification that was called a TIMI classification. And I know that Dr. Roberts was early on this kind of these kind of papers. And then we had a TIMI 0 was no flow. TIMI 3 flow was normal flow, so one extreme to the other. And there was a correlation with survival, so that if you achieved the TIMI 3 flow, mortality was reduced to 4.7%, but if you had TIMI 0 or 1, mortality was higher. So they had a way of assessing flow in the coronary artery. And what they found in the Gusto study is that if you were achieving 54% with TPA and 32% with SK, a big difference in achieving an open artery, achieving TIMI 3 flow. This led to an absolute reduction in mortality of about 1%. So changing from streptokinase to TPA at that time was associated with improved outcome. And then came along a modification of the TPA molecule by changing a few of the sites at the T and the N and the K sites that allowed this new molecule called TPA that would be favorable in terms of bolus, because the TPA from before had to be hung up as a drip for about 90 minutes. This TNK could be given in 5 seconds and could be given very rapidly. And that's what we use as a lytic today. But the concerns about fibrolytic therapy is that it is associated with the risk of intracranial bleed, especially in the elderly. And our population is getting older all the time. And there's a need for rescuing patients who have gotten fibrolytic therapy in approximately 25% of the cases where it doesn't work. And then there's always the concern of giving it to the wrong patients, such as aortic dissection, and giving it to people who have normal coronaries. The first angioplasty was done by Jeffrey Hartzler in 1980. And this was the first angioplasty in STEMI, that is, in 1980. But that was met with a lot of resistance. It was not very popular at the time, simply because it was not accessible. And fibrolytics were gaining strength in the 80s in terms of trials. And the 80s really belonged to lytic therapy. But in the 90s, Cindy Grime came out with this pivotal study called the PAMI study. And in this study, she was able to show that in 395 patients, when you look at the outcome of non-fatal MI or death, there was a significant reduction in favor of the PTCA group, which we now would call PCI, because that was done with balloon alone. And that was the beginning of primary PCI. This was the first randomized trial. We had a patient here, I remember well, who had just gotten about 5 cc's of streptokinase, and that patient had refractory VTV fib, was in shock. We took him to the cath lab. We couldn't keep the artery open. At that time, it was contraindicated to use stents, and we ended up putting a stent in this patient, and this patient stopped arresting on us and did very well. And this was one of the first reports of using stents. At that time, stents in acute MI were contraindicated. So this kind of grew. There were small studies that were published. We published our studies. And then there was this issue, should we be doing ballooning or stent? And the Americans got concerned with doing trials, looking at balloons versus stents. But we decided that we would look at comparing stents versus lytics. So this had not been done. And in this trial, we were able to show that for patients that were stented, as opposed to getting TPA, they were free from the primary endpoint. It was a composite outcome. The freedom was higher with the stent strategy. And then most importantly, we were able to show an important cost reduction, a few $1,000s, 6-month aggregate. And this was going to be a helpful study in terms of designing a STEMI program. And this is a bootstrapping 1,000 replications of the small STAT trial that was associated with showing that stenting was better and was also cheaper. We all know that time is important. I've shown you that slide of Gibson there. And this was shown also in the Gusto 2B trial, where the lowest mortality could be achieved if you could achieve a door-to-balloon time of under 60 minutes, a 1% mortality. And at the other end, greater than 90 minutes, in these patients, the mortality was excessively higher. The DANAMI trial was done in Denmark. That's why DANAMI. And in this study, they were able to show that when you look at sites that were transferring their patients and sites that had PCI labs, and when you combine them all together, there was a reduction in the composite outcome of death, MI, stroke in favor of primary PCI. This was the largest trial that compared primary PCI versus fibrolytic therapy, and it was published in 2003. And about that time, we're about to see a change of strategies. These are times that were recorded in the DYNAMI 2 study. And just to say that people were concerned about times and how quick you could get a patient to the cath lab. And this was going to be helpful for the guidelines. I happened to be in Paris, and when I was there, I was visiting Gilles Montelesco. I noted that he had this poster on the wall with French looking at pre-hospital fibrinolysis. And this was something that the French were doing at the time. And one of the emergency room physicians in Toronto put together a sort of a meta-analysis of studies looking at fibrolytic therapy in the field, and was able to show that if you gave lytics in the field, you got about a 1% mortality difference as opposed to giving it in the hospital. So the point estimate here favors giving lytics in the field. We don't do this in Ottawa, but there are cities like Edmonton where they will do that. And there's still some centers in the world where they will administer fibrolytic therapy in the field in order to save time. So there's been this debate of PCI versus thrombolysis. Has been the great debate. And this slide here, put together by Keeley, who worked for Cindy Grinds, the lady that published the PAMI trial that I just showed you not too long ago, was this slide has been shown so many times, so many meetings. All of the intervention know about this study. And it was published in 2003, like just after DYNAMI. It included our STAT study that I showed to you a little earlier, but there were 23 randomized trials in the study, and it showed that mortality was reduced when one used a prime PCI. So this study, plus the DYNAMI study, were instrumental in going to the guidelines in 2004, and this resulted in the guidelines now and giving you a choice of lytics versus PCI, but demanding that the PCI be done within 90 minutes. But one thing we need to do to get good results with PCI is to do volume. This is here at the Heart Institute, the Jeopardy rounds, a slide taken many years ago. The residents are wearing their famous T-shirts. This is the residents team. And then what we know is that it is important to do volume, and we certainly do it at the Ottawa Heart Institute. When we look at the reasons for that, it's because volume has been associated with improve outcomes. So a center that doesn't do very much volume, then I think that should not be doing primary PCI. The guidelines recommend that a hospital does at least 36 primary PCI per year. We do about 400, 500. An operator greater than 11. We're a hospital per operator. We do more than 50 per operator per year here. And then, and this is the volume that I was talking about. This slide was several years ago. Yes, sometimes everyone must infarct. I happened to be, again, as I mentioned, in Paris, and I got to see a little bit how their emergency rooms, their emergency facilities, vehicles, EMS work. The slide that I showed you was Service Aide Médicale d'Urgence de SAMU, and here's a physician that's on board, and he's doing some testing on it, showing me the test he can do on a patient. But at the end of the day, we're Canadians, and we do not have physicians on board, so we had to think a little bit out of the box. And then we have advanced care paramedics, and we were in the process of joining in with our base hospital at that time, with Justin Maloney and his crew, and training our paramedics at reading ECGs. All of our ambulances were equipped at the early 2000s with this kind of equipment in order to be able to get EKGs, 12-lead EKG strips in the field. And you can see this patient has an inferior wall STEMI. And once they would diagnose a STEMI, then they had a preset number to call at the Ottawa Heart Institute. They would call the Heart Institute. Lynn still works for us. I've spoken to her just recently. And then in the bunker, this phone's still there. This is an old-fashioned phone. The dial has been taken off, so nobody can use it to call out. But when this phone rings, it's a STEMI call coming in. And then the patient is brought in by the paramedics at being announced, and you all hear code STEMI over the speakers. And the patient is brought into a room that we call the STEMI room, where we do a target history and physical examination. See Dr. So evaluating a patient, a research nurse just behind him. And then this patient now goes to the pit stop. Everything is happening pretty quickly here. And this is Marino Labinaz, who was doing a PCI at the time. So here's an example of where we get our times. This is an ACR, and you can see at the bottom there, these numbers now are all digital, but all the different time intervals are recorded on the ACR, the ambulance call report, and we're able to generate numbers for our patients at critical time intervals and understand where the time delays are. So what we've done is we've standardized the program in a way that all patients are treated the same way. They all get aspirin, now they all get ticagrelor, they all get the same dose of heparin, and we feel that standardization is the key to a successful STEMI program. We put together our data several years ago after starting the program, and we published this paper here in the New England Journal that looked at transfer from the field. These are patients transferred from the field as opposed to patients that were brought to a local hospital by, at that time, the primary care paramedics. These were the advanced care paramedics. And we clearly showed that there was a time difference in terms of reperfusion. And this allowed us to develop this program here that has now expanded as a primary PCI program. And we get our patients all the way to Renfrew. You know, door to balloon time is a surrogate endpoint. We used our database to really look and see whether or not changing the system really had an impact. And we looked in this particular paper that we published in JACC. I think this is an important paper because we were able to show that if you actually came to the heart institute instead of being brought to a local hospital, that this was an independent predictor of survival. So using our database, I've been talking a lot about using our database. This is a paper with Juan Russo looking at patients that had multivessel disease as to whether or not they should be staged as opposed to not be staged. In other words, you do the culprit vessel first, and then you bring the patient back for a staged PCI on a site that is significantly narrowed but wasn't the culprit. And in this study, Juan was able to show that there was significant benefit. This was just an observation study, but again, this was giving us a lead into what we thought could happen in terms of a randomization trial. And this trial has been done. It's called the COMPLETE trial. It was led by Shamir Mehta out of Hamilton. And basically, on one side, you get complete revascularization. On the other side, you get culprit lesion only revascularization. This is staging the way we did it here. And then basically, the two co-primary outcomes, the first one of death or new MI, and then death, new MI, or the need for revascularization. In these cases, the two co-primary outcomes were significantly reduced in favor of complete revascularization. So now we have the habit of doing complete revascularization. The good news is we have up to 45 days to do this if we base it on the results of this trial. What about aspiration thrombectomy? And this is the TASTE trial that was done in Europe, and they almost 7,000 patients, no difference in mortality. And this proves the point that you need to do large trials. The earlier 1,000 patient TAPIS trial had shown a benefit for mortality. Now you do a 7,000 patient trial, no benefit. And then you do the total trial was done here in Canada. This was also a very large trial. And again, there was no difference in the primary outcome, as you can see here. There was no difference in mortality. There was no difference in any of the parameters. So it kind of speaks very negatively about doing aspiration thrombectomy. And this slide here out of the total trial would suggest that there is an increased risk of stroke in doing thrombectomy. So it is no longer the routine to do aspiration thrombectomy. You can do it, but not on a routine basis. And it's become basically a class 3 indication if you do it routinely. The SAFARI trial is a trial that we did here. It involved a comparison between radial and femoral. A lot had been said about radial versus femoral, and the pendulum was swinging very much in favor of doing primary PCI with the radial and doing just radial for about anything. And it was becoming a little bit on the extreme side. Our center plus a few other centers did the SAFARI trial, and we were able to show that there was no difference in mortality between radial and femoral access. We did not show any difference in secondary outcomes between reinfarction, stroke, death, reinfarction, or stroke. We saw no difference in bleeding no matter how we were able to analyze the data. So basically, we concluded from our point of view in our study, which was probably the most contemporary one done to date, that there was no difference between the radial and femoral. But that said, we put our data together, and this is Pietro De Santo, who did a meta-analysis. And given the past, we know well, the trials were very much in favoring radial approach as opposed to ephemeral approach, but now including Safari, we note that the point estimate is still in favor of improving mortality. So we do favor the radial approach, but contrary to some of the other centers, what the Safari trial has done for us is that we feel it is very important all our residents be really good at doing the femoral, and we teach the femoral. We do it with ultrasound now, and I think that our results are actually pretty good. We minimize the chance of getting retroperitoneal bleeds. This is a patient who's got an inferior wall MI, he got lytics. If you look at the time, it was 5:08 with the inferior, about half an hour later. STs are completely down. This is what Paul Armstrong would call an aborted STEMI. But unfortunately, this patient, 7:35, the STs are back up. So this is a bit of concern with fibrolytic therapy. And so we thought we'd design a study to look at whether or not we can marry PCI with fibrolytic therapy. This is using TPA as in this cartoon. We can see over time at about 90 minutes, we get about 50% TIMI3 flow. It kind of flattens afterwards. And if we were to think, okay, let's do a primary PCI instead, well, while we're getting lab ready, where we're transporting people, and by the time you get your wire there and balloon, finally you get TIMI3 flow. It happens very quickly. If you were to marry the two together, you'd get something like this. This was the concept of combining the two together. It's a concept behind facilitated PCI. The facilitated PCI basically was a strategy of planned immediate PCI after an initial pharmacological regimen, such as full dose lytics. So the idea was that if you get lytics and your lab is ready immediately. So wherever you are in the area, whether in Pembroke or Cornwall, if you got lytics, we would have a lab ready for you immediately. That's the facilitated PCI approach. And in the ASCENT-4 trial, this trial was totally negative in terms of favoring facilitated PCI. It was actually terminated by the safety committee because of an excessive mortality early on. And so facilitated PCI, as we see here with more events, is no longer recommended. So we don't give lytics and go straight to the cath lab. So we designed a study called Capital AMI, and after our publication, they did a bigger study called Transfer AMI, and this is more aligns more with pharmacoinvasive strategy, where you give lytics and follow it PCI as opposed to giving lytics alone. And in our Capital AMI study, we compared thrombolytic therapy versus a combined strategy, and we were able to show that we were able to reduce the amount of events with the combined strategy versus lytic alone. We were able to reduce that quite significantly. Those are the Kaplan-Meier curves. And then the Transfer AMI, which was a larger study that was done subsequently, showed exactly the same Kaplan-Meier curves, with the idea that it's not a good idea to let a patient with lytics alone at the peripheral center and then delay transfer and then having issues with needing to rescue, or simply in a strategy where you kind of a watchful waiting strategy to see if something's going to happen. We don't believe that's the right thing. And the recommendations now, according to guidelines, is that you should go to the cath lab after lytics. You should go to the cath lab within 24 hours. So here's our study here, the Capital AMI. There's other studies, CARES, CM3, Transfer AMI, Garcia-1. The point estimate is always in the same direction. It's always better to transfer the patient, get him over to the Heart Institute, and get him an angio within the next 24 hours. If the patient continues to have chest pain, then obviously we rescue the patient on arrival. This slide is important because it was a large study that showed that, in fact, you can delay things by as much as 114 minutes when you compare primary PCI versus thrombolytic therapy. So the guidelines now recommend that you have about 120 minutes to get a patient over for primary PCI. And if you're over 120 minutes, then you should consider pharmacoinvasive strategy. Here are the hospitals in our pharmacoinvasive strategy. You can see Deep River, Pembroke, Barry's Bay, Cornwall, Glengarry, and Hawkesbury. These are the hospitals where they lyse and ship. We always make a bed for these patients, and on arrival, they get assessed. And if they need to go to the lab, they go to the lab. If otherwise, they get a cath within 24 hours. So here's a guideline slide that we put together. These are the Canadian guidelines of 2019 that basically shows that you have 120 minutes to get the artery open if you're going to choose fibrinolytic therapy. And if you don't, then you should to choose primary PCI. And if you don't, if you can't make it from either as a transfer or from the field to get the artery open, you should consider fibrinolytic therapy as we do in our pharmacoinvasive program. Finally, we're coming on to shock. What about shock? Myocardial infarction. We were talking about time. In 1968, just before Willie Keon arrived here, the intra-aortic balloon was coming on, was making its debut. And then over 40 years, millions of people have been, treated with this. And it has been there for, it seems like forever, and everybody seems to think that this is the right thing to do with shock. But in the shock trial, there was no evidence that in STEMI patients, this is the SHOCK 2 trial by Hugo Thiel, published in New England Journal, there was no evidence that using an intra-aortic balloon made any difference in terms of survival. It made no difference in terms of your serum lactates or anything that they measured in that study. So now the European guidelines will state basically that in the setting of myocardial infarction, that it's now become a class 3 indication. The European guidelines do not recommend that routine use of an intra-aortic balloon. It should not be used in patients with cardiogenic shock. There are some exceptions, but as a routine, we should not be using the intra-aortic balloon. So that kind of leaves us, what are we going to use? Well, the Impella is kind of a new device around the block. It's very expensive, several thousands of dollars. And it is being now tested to see whether or not it will help patients with shock. Basically, it's a catheter that's positioned in the ventricle with a pigtail, and it takes blood and has a pump that pumps it out into the aorta. So the Impella device can be, there are different models on the market. The one that gets us the biggest cardiac output is the Impella CP, which can be put in through the femoral. So now there's this concept that is kind of a paradigm shift that maybe we should be thinking of a new way of thinking, maybe unloading the ventricle. And the Impella device would be ideal for this because it can unload the ventricle very quickly. And the reason that there is a thoughts behind this is that factors like wall stress and blood pressure and stroke volume, they increase the ventricular load. And if you can reduce the wall stress, and if you can decrease the volume in the ventricle, perhaps you can decrease the myocardial oxygen consumption. And so there's data that if your pressures within the heart are higher, if you don't unload the heart, there's data to suggest that higher pressures are associated with more muscle damage, and more muscle damage associated with lower survival. So they've come up with the idea that if you unload the ventricle with the Impella, you reduce ventricular wall stress, you decrease your MVO2, increase forward and flow, decrease ventricular pressure and volume. And they explained all kinds of mechanisms by which it limits ischemia, that these are enhancing the activity of kinases known to limit ischemia, reperfusion injury, preserving myocardial integrity, increasing the activity of cardioprotective cytokines, enhancing microcirculatory coronary flow. A lot of bench work has been done before this, and the belief is that LV unloading leads to the enhancing of these kinases. And it's believed that you need to do this, at least the unloading has to be done at least 30 minutes before you actually reperfuse the artery. So can you imagine now, you got a patient comes in with a STEMI, you got to put this Impella in, you unload the ventricle first in order to get, these pathways kind of activated that will promote, healing and basically lower the amount of injury. And then you open up the artery, because it is felt that if you open up the artery immediately, then these pathways will not be activated, and you will end up having more myocardial damage, and hence you will not improve your survival. So they've come up with this They've done the pilot study already. It's only 50 patients. And now they're on to a bigger trial called the STEMI DTU, so door to unload. So the time that you come in to the time that you unload, a new concept, and they're randomizing patients basically to get the CP, the Impella CP implanted, to wait 30 minutes, you do your PCI, and you use it for support for 4 to 6 hours, as opposed to the other arm is doing a coronary angiogram and then doing your PCI immediately. The primary endpoint is basically a CMR endpoint. Secondary outcomes include clinical outcomes such as mortality. Concerns about this? Well, I looked in the database, and what I did is I started taking out all of I looked at the mortality in our database over a period of 2004 to 2018, and I took out one at a time the different exclusion criteria, leaving behind a smaller and smaller population, obviously. But I come to the point where when I look at the patient population that they will be randomizing, and I don't include other things in there like COPD, vascular disease, we may be looking at a very low risk population. So I don't know that the population they're going to be looking at will have any benefits in terms of mortality. It's a proof of concept study, and they will need to look at whether or not there's any salvage as shown on the CMR. So this is going to be a proof of concept study. There will need to be a mortality study at one point, and at that time they probably should be thinking of a higher risk population. I don't know if I'll be able to show you this slide here. Let's see. So this is a patient that presented to the Ottawa Heart Institute several years ago, many years ago. And then Dr. Glover did his angiogram, and he was having an anterior wall STEMI, and he was like 10 feet outside the door of the cath lab when we were evaluating him. And then he was totally KILIP 1, stable, having some chest pain. It took him to the cath lab. Next thing you know, he's fibrillating. He's going shocky. And Chris quickly did his angiogram. At the time, Mike Froschel, I believe, was a resident. What we see here is a normal right coronary artery. But what's real concern is the next slide. And you see here the left main is occluded. Now, you may have time to put in an intra-aortic balloon on a patient like that, but I doubt that you have time to set up for an Impella at this time. And most people would probably want to do, the first thing they want to do is get a wire across and get some flow going if you want to put a balloon afterwards. But I know the first thing I would be doing is putting a wire across this. And there's no way that I would be able to sit on a stool for 30 minutes while I'm unloading the ventricle before I do PCI on this patient. So, you know, I think this DTU study has to hit the sweet spot. This patient would not qualify in any way, shape, or form for that particular trial. And when you look at the results that Chris got on that patient, a bunch of stents went in, and now you can see the intra-aortic balloon behind, but you know, he got a really good result, and that patient has done well over the years. Finally, other technologies are around, and this is a patient that had got lytics, came over, and then got a stent in the LAD, and then was only on clopidogrel, got back to the CCU, and then started infarcting again. The essays were up. We brought the patient back, and what you're seeing here is an OCT, which allows us to use a fiber optic, basically light, to look inside the coronary artery and see what the problem is. So after reperfusing this artery, we had a look, and we can see lots of clots seeing on the short axis view. The stent looks like it's not really well expanded. So what we did for this patient, we changed our pharmacotherapy, got loaded with ticagrelor, got an eptifibatide, which is a 2B3A, and then got further balloon and expansion of the stent. Just to let you know that there may be a role for new technology in order to improve the outcome of our STEMIs. There's going to need to be a trial, perhaps in the future, looking at the role of these new technologies in order to improve outcome. So the treatment of STEMI is truly the Grand Prix of cardiology. It is a bit of a race. A race for time. And I think that we get about 400, 500 primary PCI a year. We get 150 to 200 pharmacoinvasive STEMIs a year. There is no more frequent emergency on a daily basis. We hear code STEMI probably an average of twice a day at the Heart Institute. So I think that it has got us focused but I think there's a lot to be done ahead with STEMI patients. Future directions, there got to be better ways of improving our medical contact to balloon time. Time to discharge, we start discharging patients now at 1 day if they're extremely low risk. After 1 day in the hospital. New technologies, I mentioned the OCT, there's FFR, reduction myocardial infarct size, whether we do it pharmacologically, and there's studies looking at that, and devices such as the Impella. Management of LV thrombus, I haven't talked about that at all, but there is a need to know and understand how long you keep people on anticoagulants if they have LV thrombus. Do the DOACs or NOACs do the trick? We need to find a way of reducing complications, and we need also to improve patient education in terms of using 911 and not transporting themselves to a hospital. Need to learn basic CPR. So the credits for a lot of the work that we've done at the Heart Institute go to EMS, to our ED staff, cath lab staff, our nurses, our PCI fellows, cardiology residents, and the interventional group. And on that note, I will end this talk. I hope I haven't gotten too overboard in terms of time, and I'll be happy to answer questions. Thank you very much.
Wow, thank you so much, Michel. That's actually an unbelievable journey that you have undertaken. And, it's really actually, I think, underscores your determination and persistence and, passion, and ultimately succeeded, sort of beyond anybody's imagination. And but I agree that there are still, major opportunities, to improve on what we are doing, but it is already a remarkable journey. Maybe just a comment that there are questions, in the Q&A boxes. So I share your concern regarding the DTU study. I think they, I think they're thinking about things like post-conditioning and things like that. I'm not quite sure that's actually the context in which those original concepts apply. And I absolutely agree. I think in the majority of cases, we already seen that, time is a muscle, and that there may be pharmacological strategies, to help with those, but certainly not at the expense of, delaying flow. Yeah, so that's my take on that. Maybe a question. Question from Rob Inlands, and Rob just want to thank you for your leadership and outstanding work, making STEMI such a flagship program at the Heart Institute. And so the question is related to the field decision-making for the critical ill patients. And, for the direct transfer, are there tools that may help the paramedics with the decision-making? And this is particularly, I guess, on the mind of Rob and many of us, because of the transition of TOH location and, how the acute care is going to be managed, and access to ER and all that. So a question, I guess, relate to that. One is an in-field decision making, but also, are there ways in which we can mitigate the transition period?
So Ottawa is kind of unique in that we have the Ottawa Heart Institute that was sort of put right in the middle of, right in the center of Ottawa, in the Ottawa region, as opposed to being at one end, like the Palladium Corral Center, all the way at one end. I think that Dr. Don and Beanlands and Willie Keon thought it was really good to put it right here because it's right at the center. The other thing about Ottawa is a good portion of the population lives in a very dense area close to the Ottawa Heart Institute, as opposed to Edmonton, which is more spread out. And so when a paramedic picks up a patient, and the likelihood that the travel time is going to be long is, on the majority of the cases, it's relatively short. So, they're kind of judged as to how long they take in the field. And I think the paramedics take it really at heart in terms of wanting to make the right diagnosis. And they are very receptive in terms of being trained and wanting to be part of the team. Sometimes I thought about it, maybe we should go with something like smartphones or something like that. The question is that the pathway that we have right now works pretty efficiently. The false positives from the From the paramedics, there's relatively few. We're talking about maybe 15%. And we got to be careful when we use the word false positive. There's false activation and false positive. For example, if bring somebody with ST elevation and they turn out to be something else like a stress cardiomyopathy, then I think that this is not necessarily a false activation, maybe a false positive, normal coronaries. So I think from that perspective, I think that the paramedics do actually quite well in terms of calling out the STEMIs. Different jurisdictions do it different way, depending on the logistics and also depending on how they want to be consulted. Some of us feel that if we were consulted on every chest pain, because of the volume that we do here at the Heart Institute, the interventionist would be on the phone all the time. And so we're kind of glad that the paramedics are actually trained to do so and are not sending us ECGs on our smartphones every 20 minutes. And that could be a challenge, especially on weekends when we're in the cath lab. So I think there are ways of improving perhaps time. I think the COVID has been really particularly difficult for us because it hasn't allowed us to get closer to the cath lab. When the patients are brought in, they're actually brought in our CICU as opposed to being brought in the bay real close to the cath lab. I think ideally they should be brought right in the tower, in the cath lab like it was before we built the tower. Before we built the tower, the STEMI room was actually right there next to the cath lab. And I think that is truly the ideal situation. But right now, during the COVID period, it has made it a little bit more challenging in terms of getting the patients over. They have to be screened. They're all brought in the CCU. And there's really a disconnect between the CCU and the tower. You can't really see the other person. So you have to call and try to figure out who's ready and has the patient been adequately screened. So I think that once we move on beyond COVID, we ought to rethink on ways that we can reduce furthermore the time. And there are some scenarios that we could explore.
Yeah, great. Very, very thoughtful. Yeah. And actually, I had a question kind of, Dr. Masana had a question. I don't know whether Terry wants to directly ask the question. Yeah, because I see that the question is not.
Do you hear me?
Yeah. Yes.
Okay.
Go ahead.
Well, thanks a lot. I mean, great talk. Thank you very much, Michel. And really, your pioneering work is remarkable. I have actually a difficult question for you.
Here it comes.
I'm always puzzled by the provincial guidelines, which actually set up our funding. And for cath lab, it's not the wait list. It's the percentage of STEMI that present directly to the PCI hospital in less than 90 minutes. So they put a number here. And the number is the Ontario average is 45%. So they say that 45% of the patient, I'm not talking the non-PCI hospitals. So the 45% is the provincial number. So that means that like 45% only from the STEMI patients coming to us, coming to Ontario provincial hospitals, because I know our number. I'll disclose my number after my question. Okay. So in 45% only of the patients are referred to a PCI hospital within 90 minutes of their infarct. So is that a number which is, how do you feel this number is? Is it a good number? Could it be improved? Could it be higher? This is less than half. This is the provincial average. And then if you want, I can tell you what is our number.
Well, I think our number varies a little bit from time to time, but I'll say this. I think that the provincial guidelines are behind the times. I think that the Canadian guidelines indicate that it's 120 minutes, not 90 minutes. And if a patient takes 91 minutes, suddenly he doesn't count it as part of that percentage. And remember that slide that I showed you regarding this large observational study where the time delay was up to 114 minutes. The guidelines changed at that time, allowing us 120 minutes from the field. So we're talking transportation from the field to the Heart Institute. And I think that we don't have an emergency room. So there is nobody that walks into an emergency room at the Heart Institute. And the 90 minutes applies to those patients who walk in a hospital where there is an emergency room and has a cath lab. The Civic Hospital, for all intents and purposes, is considered to be a separate hospital. So it doesn't count as part of that. So when we look at the field to cath lab time, the numbers don't look as good as they should be in terms of a percentage. But one thing I can tell you, all the hospitals are struggling to achieve that number at the 75% target. So what the ministry would like us to do is to achieve 75% of the time, a door-to-balloon time under 90 minutes. So first of all, the 90 minutes is wrong. And two, the target is extremely, extremely difficult to achieve. It's so that I think that it was based on some of the stuff in the States on the race team, where they have all kinds of exclusions. While in our studies, we don't exclude people, whether they have dementia, whether they have cardiac arrest, whether they don't speak our language. You know, we still take them to the cath lab, and they're counted in the database, and they're counted as a time. But if you look at the race data that was presented, they have all kinds of exclusions. So they're actually cherry picking. And so when they look at their times look better. So I think the ministry should look at the Canadian guidelines and look at what the real door to balloon time should be, or should be allowed, and that's basically my answer.
So they put the 120 minutes from the non-PCI hospital. So the average of Ontario for less than 90 minutes for STEMI is 45%, and our number is 38%. So we're actually 7% under. And I can tell you, we can discuss this offline. I have every single board meeting every quarter, because it's monitored for the hospital service accountability agreement. If you don't fill the criteria, basically they're going to suspend your funding or reduce your funding. I've talking to them forever. So I was wondering, and I told them that the criteria were not good. They were not adjusted to the reality. Unfortunately, it looks like you colleagues in Toronto do not have the same enthusiasm or the same kind of collective strengths to go to the ministry. And I think I just want to let you know, Michel, considering your leadership, I would advise you to really talk to your colleagues in Toronto and form a group and pressure the government to change their guidelines, because if they decide that this is the criteria by which they're going to fund the hospitals with STEMI program, I think it's a bad idea on their side.
Yeah, the Toronto has, some of the Toronto hospitals are very similar to us, and some of them are significantly better, but there are only a few of them that are better. Hamilton is a little bit like us, and they have a very aggressive primary PCI program, very large primary PCI program. So there's a lot of factors that go into producing these data. I also think that our LIN, we serve a LIN that's fairly big. We serve, actually, we didn't mention this, but we serve also Perth and Smith Falls for primary PCI. We serve Renfrew, which is quite a distance. And when we look at these hospitals that are quite a distance, they would never go back to fibrolytic therapy. It would be unacceptable to them to go back to fibrolytic therapy. They run the system pretty efficiently, given the distance that they have to travel. And there are other issues that we could do in our own backyard to improve. We could improve, for example, door to ECG time. From our point of view at the Heart Institute, we can't see the patient until he's had an ECG. Like if the patient takes 30 minutes in a peripheral hospital to get an ECG, that will impact on our own first door to balloon time, because the door time for an intra-hospital transfer starts with their arrival at the other hospital. So there are many components of that first medical contact to balloon time that need to be addressed. I think the Heart Institute here, when you look at our times from arrival at the Heart Institute to the cath lab and getting ballooned, they're really awesome. I think the people here do an awesome job. There's a few tweaking that we can do. I think COVID made it a little bit more difficult, but I think in terms of those times, we do a really good job. I think the tweaking has to be done perhaps in some other situations. And so finally, Toronto, I think you're right. I think that we should get together with some of the leaders in Toronto and address, because these are based on like pre-recent guidelines. These are based on 6-7 year old stuff. You know, they judge us by a yardstick that is actually old fashioned.
Yeah,
I can help you out for this. This is an initiative you should take. You have to know that actually we don't have any more lean for those who are listening to us. There is no Champlain lean anymore. We have 5 super leans. And now the core health has been folded under Ontario Health. So they are revisiting the guidelines and the criteria for funding the hospitals. So I think it's a perfect timing to use your leadership that I really salute once more and your experience to get together with the guys in Toronto to push the ministry to find actually better these programs. Thank you so much for your leadership, Michel. Congratulations again.
Thank you, Terry.
Yeah, I agree. I think, you know, getting the proper metrics is important, right? You know, because otherwise it's apples or oranges. And maybe just a final, very brief question, because Rob been waiting to get
so
his
just
words
to
in
add
as
to
well.
that, just to add to some of those points, you know, this whole business of door to balloon, like our door to balloon time is good. It's because it starts in the field. And for the reasons that Michel said, we're penalized from other centers, even the transportation, because they're coming long distances. So absolutely agree. It's, you know, we've been arguing with Core Health for years about this. I know Michel's been vocal, myself, Eric have been vocal about it, but it's really time to make the change. I fully agree. And Michel, it would be great to have your leadership to enable us for that.
Great. Yeah. So thanks so much for the comments. And in view of the time, I'd really like to, on behalf of everyone, you know, just thank Michel for the tremendous amount of work over the decades, you know, really serving the population here well, but also, you know, setting the standards of care for the entire field. And so there's no question that, you know, the journey continues, and there are always, you know, sort of the next level of challenges, and Michel will be there to help us, you know, to coordinate this. And so look forward to more updates down the road. And so it'll be twice up on time. So thank you so much, Michel, and I really appreciate it. Next week, it'll be Navin Nader, who actually is going to be delivering the Servier lecture. So look forward to seeing everybody at that time. It will be another exciting research round. So thanks again, Michel. Thanks everybody for joining us. Have a wonderful day. Take care. Bye-bye.